Hello, I'm speaking today with Dr. Mark Lewis, who is an oncologist at Intermountain Healthcare in Salt Lake City, and also a member of the NETRF Board of Directors. Dr. Lewis, thanks for being with us so that we can talk a little bit about COVID-19 and what we know now.
Yeah, Elyse, it's a privilege to see you and to address our audience together. And I think it's very appropriate because even though we spoke in April, our understanding of the virus and the landscape of the pandemic have changed just in a matter of months. I think we're seeing a really accelerated evolution of our understanding. And so it's great to kind of provide an update now.
Well, thanks for your time, Dr. Lewis. I know when we talked in April, things were very different. We were all quarantined in our house. The virus was worst in California and here in the Northeast.
Mm-hmm.
And we were quarantining our mail and scrubbing our groceries. So things have changed. What do we know now about the virus? And is the virus that we're contending with today the same strain as what we had out there in March and April?
Yeah, great question. So there's basically three ways that the virus can spread. So it can spread as droplets. So if we cough, sneeze, or even exhale forcefully, there's these tiny little basically fluid molecules, if you will, that go into the air and typically don't last very long. However, even there's a possibility of generating what are called aerosols, which are literally sort of smaller parts of the virus kind of hanging in the air, and they can do that for a little bit longer. And then finally, there's what's called self-inoculation, which is the person's hand going to their mouth, nose, or even their eyes. And that allows the virus to penetrate through those surfaces. And that's really only possible if you're touching a contaminated surface. And we'll talk later about which surfaces might particularly harbor the viruses and which don't. I would say that probably the greatest risk is becoming complacent. I think we're all tired of this. And it's very easy to let our guard down and ask ourselves, haven't we been doing this for long enough? But unfortunately, the virus persists in our population and really will do so, I think, unless we are really stringent about person-to-person transmission, we have a vaccine, and or we have the ability to detect who has really meaningful antibodies. In regard to strains, it's very interesting. So the coronavirus is a family of viruses that have existed for a very long time. In fact, 4 different strains are responsible for what we would colloquially call the common cold. And then other coronaviruses include SARS and MERS, the Middle East Respiratory Syndrome virus. But with SARS-CoV-2, obviously our science has had to move very rapidly, and it appears there's possibly up to 6 strains. Now, interestingly, you asked if we, meaning here in the US, are dealing with the same strain. It seems like we are. So the Wuhan virus that originated in China is called the L strain. Here in the United States, we seem to be dealing with something called the GR strain. And then Europe, for instance, seems to be dealing with a different strain called G, where the spike that allows the virus to enter our cells may be a little bit more prominent, a little bit more threatening. So it's a long answer to your question, but yes, there do seem to be some slightly different strains, and it actually may have to do almost as much with host biology, meaning ethnic variations in susceptibility, as with the virus itself.
So we're about 8 months in, and again, thinking back to when we talked back in April, we were cleaning off our takeout containers, we were scrubbing groceries, we were quarantining mail. What do we know about transmission through surfaces? And well, yes, we want to be careful. How careful or compulsive do we need to be with some of those things?
Sure. So we've tried to study that in the laboratory. There was a really very interesting article in the New England Journal of Medicine that we can link to, looked at, again, both aerosol and surface transmission of the virus. And basically, it depends on the surface. So copper may actually be the least sort of hospitable to the virus. The virus maybe can persist on copper, and this is, again, in laboratory conditions, not real world, for a few hours. Whereas, and this maybe gets back to sort of our meticulous cleaning of things arriving in our homes, whether by mail or hand delivery, it can last longer on plastic and cardboard. And again, in sort of like a perfect storm for the virus, it can persist on those surfaces for up to 72 hours. So what I've told people is, handle your mail and your groceries, typically wearing gloves, and then discard the packaging, as soon as you can. The contents should be fine. But that outer layer is potentially still a vector for transmission.
And that's enough virus to transmit the disease?
Great. Okay, that's a great question. So what we're looking at is really the difference between detectable virus and then enough to cause illness. And those really are different. So what we're talking about is, for up to 72 hours, you can still find a tiny amount of virus persisting. But that probably means that, putting your groceries in sort of quarantine, if you will, for 3 days, that's probably overkill. And I certainly would not necessarily recommend that. So that's the problem, is translating what we can see in the lab into the real world. And again, I think people should err on the side of caution, but then there's sort of reason as well. And so we don't have to be too panicked that those are routes of transmission. We just have to take, I think, very basic precautions. And also to remember, the virus can, short of these surfaces, really only survive person to person. So again, I would point out that social distancing and masking probably go a lot farther towards halting the spread of the virus than even decontaminating surfaces.
And that does bring up a good question about masking, because we were at the mask or no mask stage when we first talked. And
Yes.
Now we all know we should wear a mask. And there are mandates in a lot of places, no mandates in others. How do we understand the kind of flip-flop and whether we wear a mask or not, and how does that impact the willingness of people in different states to follow those recommendations?
I think the reversal of that stance has actually shown a lot of mistrust, and I think that's unfortunate. I think, again, back in March and April, healthcare workers were really facing a very critical shortage of personal protective equipment. So as best as I can surmise, the federal recommendation at that time that not everybody should mask was largely driven by the concern that the general population was going to mass purchase and even hoard masks and then deplete the supply available for medical professionals. I know that sounds selfish, but because we are in regular contact with either potentially infected or actually infected patients, it's not just a matter of our own self-preservation, it's a matter of our ability to continue working in hospitals and in clinics. So I think, when people were mass buying toilet paper, for instance, I think that was sort of a worrisome signal that, there was going to be this sort of kind of herd mentality and sort of a consumer impulse to mass purchase masks. And I think now that we have, thankfully, a slightly more robust supply of personal protective equipment, including masks, I think that that's the main reason that the recommendation changed. And also, frankly, nobody 8 or 9 months ago was an expert on SARS-CoV-2. And so we can talk a little bit more about this, but science evolves, and I know it's hard. I know we want a canonical truth that does not change. But again, actually, I think that the rate of research and understanding is actually pretty remarkable, all things considered. It's not nearly as fast as any of us want, but it's one of the most rapid evolutions I've witnessed, at least in my career in medicine.
What's the thinking now about whether cancer patients in general and NET patients specifically are more vulnerable to the virus? Do we have enough even anecdotal evidence on that? Have we changed thinking on that since the beginning?
Yeah, actually, the thinking has changed. And I'll be honest, I was one of the first people that I know of, at least, to write about this concern that we were going to see an acute spike in mortality in our patients with cancer, including NETs. Thankfully, Elyse, and I know it's still relatively early days, that has not transpired, which is a huge blessing and a weight off my shoulders. And the best study I know of is actually one, again, not to self-promote, that my institution, Intermountain, is participating in, but it's really a national effort. It's called CCC19. So that's the Cancer and COVID-19 Consortium. It's based out of Vanderbilt, but at this point involves hospitals and cancer centers across the country. We're basically aggregating all our data. And the people that we put into the database are patients that have both either a history or a current cancer and a SARS-CoV-2 infection. And what's really been fascinating, and again, I'll say this carefully, encouraging, is it does not seem to make a significant difference in outcome, whether you've had cancer before, finished treatment in the last 4 weeks, or are on active treatment. And this is going to be sobering, but the composite endpoint in the study looked at really 4 very serious things. Number 1, were you sick enough to be admitted to the hospital? Number 2, if you were in the hospital, did you go to the ICU, the intensive care unit? Number 3, if you were in the ICU, did you get put on a ventilator? And 4, did you die? So obviously that's really, really hard endpoints. And again, there was no difference based on whether you have had cancer in the past, just finished treatment, or on treatment. And then to the net point, many of our patients, thankfully, do not have tumors with a growth rate that actually requires frank chemo. Many people are maintained on hormonal therapy like somatostatin analogs. And actually, one of the subsets in this study looked at non-cytotoxic therapy, meaning these hormonal approaches. And the most typical patient in the study would be, say, a woman with breast cancer on hormone treatment. But really, it's not too big of a stretch to extrapolate that also to the patients out there that are on somatostatin analogs. And again, I would just reassure our NET patient population that, again, so far, and this is a consortium that's going to be iteratively updated. This was first published in May in The Lancet, and I suspect a new update will be coming soon. But at least in those early months of the pandemic, it was not changing outcome if you were on treatment, including even chemo, but also including hormone therapy.
So that would speak to some patients who were considered immunocompromised.
Exactly. And it's really fascinating. It goes to show you that this is not necessarily an entirely intuitive virus. I guess I would point out that the immune system is very complicated, and even traditional chemotherapy that might lower your defense against bacteria, it might not compromise your immune system against viruses, and that's a massive distinction. So I think there's a lot to that. I'll also point out that a lot of our chemo patients are actually getting steroids as pre-medication to mitigate allergic reaction and also help with nausea. And it's a big stretch because really where steroids have been proven the most is people that are in the hospital and require supplemental oxygen. But some of us wonder if there hasn't been sort of an incidental protective effect of steroids, which are sort of the ultimate anti-inflammatory agent. Because again, the way the virus actually hurts you, obviously it's an infection itself, but it's your body's sort of over-exuberant response to the virus, that inflammatory surge. You might have heard of the cytokine storm. That is most often why people get catastrophically ill. And maybe in some strange way, we're mitigating that with these steroids. We just don't know yet.
So one of the other concerns for many months was that hospitals were not open for screening or preventive care, or even in some cases for non-emergency treatment.
Yes.
With hospitals opening up now and physician offices open with all of the protocols, what are you seeing with patients who maybe delayed some care or perhaps are slightly delayed in their diagnosis? I mean, what's the concern that you have as a physician for those patients who just couldn't get in
right
for care or were not able to address symptoms for maybe 6 months?
Yeah, it's funny that you should say that, because that's been really, I think, a national concern, even an international concern. The American Society of Clinical Oncology, unfortunately, estimates that we may see a latent rise in cancer death. For many years now, we've seen, again, not as nearly precipitous a drop as we'd like, but we've seen a fairly steady decline in death from cancer. A lot of people attribute that to less rates of smoking, and obviously lung cancer is a highly fatal disease. However, the American Society of Clinical Oncology estimates it might be up to 10,000 otherwise preventable deaths that we'll see from cancers with delayed screening. Now, again, that may be an overestimate, and we're not trying to fearmonger, but we know that screening is traditionally recommended for, say, colon cancer, breast cancer. Frankly, NETs, I'm actually less worried about the impact, because with the exception of some hereditary syndromes, it's actually not that common to screen for NETs. And also, we really tried, at least at my center, to say that, listen, cancer care is essential. And we've had very minimal delays in patients on active treatment. So again, that doesn't preclude a population out there who are getting delayed in diagnosis or delaying screening. And that is a real concern. But for my people on active treatment, I've actually been able to maintain their schedule almost without change, and that's been very gratifying. And it really has to do with prioritization of resources. As you said, there are some procedures that are considered elective. Probably the common one to cite is, say, joint replacement. People with arthritis may suffer terrible hip pain, but their hip replacements were being deferred there for a while, hopefully with no impact on mortality, but probably, let's be honest, with some decrement in quality of life. And the other challenge we face now, Elyse, is that we might be in a little bit of a honeymoon period here, and not that the virus is in any way gone. We probably have a month or 2 months before the traditional winter time and fall respiratory viruses arrive, like seasonal influenza. And so some of us that do elective work are trying to kind of rush and catch up with our backlog before that happens, because there's a real concern there about these viruses converging. And it's not necessarily newsworthy because unfortunately it's become so commonplace, but we lose tens of thousands of people to seasonal influenza every year. And so that being additive or possibly even multiplicative with COVID-19 is very worrisome. So again, this is probably the time to sort of take advantage of at least some control and get the elective procedures done while we can.
And I know one of the discussions that so many families are having right now, because in all states, to one degree or another, the economy has reopened. Everything's open, from stores and restaurants, more capacity than we had a couple of months ago. But the school decision seems to be particularly agonizing. And I've talked to so many families who are trying to make the best decision that they can. But what do you recommend, or what's some of the consideration for people who have nets and are trying to figure out, should they let their kids go to school or not? And how do you protect people coming back into your home? What are your thoughts on that?
Yeah, obviously it's such a tough issue, and there's many dimensions to it that actually go far beyond medicine to obviously include education. And then frankly, I have the utmost empathy for working parents who now may have to take it upon themselves to sort of be de facto teachers as well, and taking on not just that responsibility, but finding the time and being able to continue their work if that's how they earn a wage. So that's very tricky. So I'll say two things. Number one, I'm part of a dual position couple. My wife is a pediatrician. We are fortunate in the sense that she does urgent care, and her shifts are largely on nights and at weekends. And so she has taken upon herself to be our children's home teacher. And I realized that we're in a very privileged position, and not everybody has the means to do that. So, but I will say that from a pediatric perspective, she was concerned that our children, even if they wouldn't become sick themselves from the virus, they could transmit it to us, and then that could compromise our health and our ability to take care of patients. So it was kind of a multi-step calculus. But here's what's interesting, Elyse, is there may be a real bifurcation in safety based on the age of children. So obviously when we talk about school-age children, it's a pretty wide demographic. We're talking about kindergarten through 12th grade. That's a big spread. Children under the age of 10, and there's good science to back this up out of Korea, are probably less likely to spread the virus. And there's a couple of things going on there. Even if they have an identical viral load in, say, their mouth or nose, they actually do not cough or sneeze nearly as forcefully as adults or older children. And then secondly, and this is kind of interesting to think about, they're lower to the ground. So that whole aerosol business we talked about earlier, and again, I know it's gross to talk about droplets and things in the air, but they are probably slightly lower than the air intake, if you will, of taller adults. So for various reasons, even though you might think they'd be less good at hand washing and masking, and they probably are less good at those things, younger kids, so elementary age, are probably less likely to spread it than kids in middle and high school. So that's actually one factor that kind of goes into the parenting decision too. But it's such a tough decision on all levels. My main concern actually, and I said this earlier without trying to be too much of a pessimist, if the fall gets really bad, either with a resurgence of COVID and or with the addition of seasonal influenza, I think a lot of these in-person schools are actually going to be forced to go virtual. And that's actually the other reason we chose to just do it from the beginning. And again, we're lucky that we can, is that we didn't want to start our kids in person, potentially put them at risk, and then just have our hand forced into virtual learning. We thought it might be more, or less, I should say, disruptive for them if we just kept it steady state the whole academic year. But we're going to have to see. And I think there's been some pretty early warnings out of some high school reopenings, some college reopenings. My alma mater, for instance, actually just shut down freshman orientation because they had positive cases. So I think it's a tough time for all levels of education, but particularly I worry about middle, high school, and then even college.
Yeah, because that decision about sending your your child to school, as you mentioned, you're worried about having them come back home, even
Right.
if they don't get visibly sick.
Right.
If you're a cancer patient, either in active or in surveillance treatment.
And then the other thing to realize is, multi-generational contact might also be pretty risky. So I'm talking to you from Utah. We're the youngest state in the nation. Our median age is 30, but it's also very common here through both church and just family gatherings for there to be multiple generations in the same household or building. And that actually probably is the riskiest part. The one variable that we really can't change, obviously, is our age. And as a very broad stroke, by decade, really starting at 45 and then just increasing incrementally, it seems to get more risky. That may be because as we age, the receptors for the virus are more prominent, not just in our mouth and nose, but down in our lungs, and that's where these nasty pneumonias come into play. So the cases I've seen here in Utah, again, the children may not even be visibly sick, but when you do contact tracing, it seems as if children, and again, probably more the teens and the young adults are able to transmit to older adults, even if there's not, a visible sickness. That's the really tough part, is even with the flu, there tends to be a more rapid turnaround from when you get the virus to when you know that you're sick. And it's kind of like the perfect storm. There's almost maybe up to 2-week window here of latency where you can be incubated and you can be spreading it around and have no idea. And again, kids may never become symptomatic. So it's really hard for this sort of silent spread to think about that and also to treat everybody, unfortunately, as if they're a potential risk to you.
Now, you mentioned a few minutes ago the PPE shortages early on. In the last couple of months, have you noticed any shortages of drugs or anything that would potentially impact the NET community?
Yeah, that's great question you asked that. So the FDA actually has a very active and constantly updated list of drug shortages. So some of the medicines that our patients depend on, like say the somatostatin analogs or insulin, if they're having pancreatic difficulties, thankfully those have for the most part not been in short supply. As you know, that the main two manufacturers of somatostatin analog are Novartis and Ipsen, and both companies have done a nice job of keeping us supplied. In some cases, even permitting us to have home health nurses go to the patients' homes and obviate the need for them coming to our center to get their every 28-day injection. So that's been really a wonderful benefit for some of our folks. The medicines that have been in short supply, somewhat unsurprisingly, have been the ones that have shown the most promise in COVID. So dexamethasone, for instance, as I mentioned earlier, if you're hospitalized and you develop a need for oxygen, it does seem in very well validated studies now, largely out of the UK group at Oxford that launched what's called the recovery study, it does seem that dexamethasone helps. Is it a panacea? No. But that has sort of produced a rush on dexamethasone, which is a problem for me insofar as I mentioned earlier, I give it a lot before chemo. It tends to prime the body to receive the chemo, especially some of our chemos that contain heavy metal. And it also works actually as a fairly effective anti-nausea agent. So we actually have been so low on intravenous dexamethasone that in a lot of cases in chemo, we've actually switched to pills. And then the other drug that's been in short supply has been remdesivir. So that's another drug, really an antiviral agent that again has shown some promise in COVID. It's been very hard to get. For a while there, we were actually completely out of it. My hospital system, and we're the largest healthcare system in Utah. But I think the manufacturer of remdesivir, Gilead, is ramping up production because they know it's a potentially valuable drug against COVID. So those are the main two shortages that I've been concerned about. And again, they actually have less to do with NETs than the pandemic itself.
And when we talk about studies, there are a lot of reports coming out. Some of them are case reports of one case.
Yeah.
Some of the studies have famously been retracted.
Yes.
How does the average person, non-scientist, non-physician, know whether to trust any of this information?
I completely agree with you, Elyse. And honestly, there have been some really egregious cases of either misinterpretation of data or frankly, and this is the most ethically repugnant, fabrication of data. And so I'll go back a little bit. The most famous infamous example of data fabrication I can think of, at least in recent memory, was in the late 90s. There was a South African researcher who essentially made up data saying that bone marrow transplant worked for women with breast cancer. And so literally thousands of women got bone marrow transplants, which is one of the most intense therapies we can offer, needlessly. And it was because this one guy, for whatever reason, vanity and desire for peers to praise him, I don't know why, he made this up. And so that was over 20 years ago. And since then, we had been very, very sensitive and pretty meticulous in reviewing manuscripts and data before we publish them. What's happened this year, and it's been really unfortunate, but on one level understandable, is the editors of these journals, like say the New England Journal of Medicine or the Lancet, traditionally extremely reputable publications, have sped up their turnaround time. And it's because, and again, I think this part's defensible, in the middle of a pandemic that's threatening, literally millions of people, there's a real pressure to get new information out as quickly as possible. And so frankly, I think there have been some shortcuts. The most famous retraction I can think of was in the Lancet. It was a study, an international study that reputed to have looked at almost 100,000 patients, but some of those patients were made up. And that is so deeply unfortunate because one bad actor can undercut the public trust in our scientific method. And again, these editors of these journals have been under a tremendous amount of pressure, but that does not, unfortunately, excuse sloppy review. And so what I would say is 1 or 2 bad studies, and there have been a few, do not actually necessarily mean that all the other ones that were conducted more ethically and more accurately, it doesn't mean that they're all worthless, but I do understand why the public is struggling. So I'd say this, the gold standard in any trial really is a randomized controlled trial. So when you're reading about a study, as you said, it can't even be describing a single person, which is really our weakest evidence base, where we really try to kind of get rid of all the confounding sort of noise and find that right signal is through randomization. That's tough to do, but it is doable, especially with large populations affected by COVID. And then again, you want to look at the number of people enrolled. And again, I know I just cited the massive Lancet study where unfortunately that was partly fabricated. As a very general rule of thumb, the more people that are involved in the study, again, the more reliable or generalizable the result will be. And then finally, and I say this with some trepidation, I would actually look on social media and websites like yours to see what's getting amplified. When I first joined Twitter, it was my first day as faculty at MD Anderson, and I wasn't doing it as a frivolous pursuit. I was doing it because my chair there said, listen, this is how you can see what matters to your peers. And good stuff will bubble up. And things that are reputable, or at least believable for the moment, will tend to get amplified. And so there's a lot going on right now in social media. Unfortunately, there's a lot of misinformation and trolling. But on the other hand, depending on who you follow and how much you choose to trust them, you can kind of see what other people are deeming worthy of attention. And so I think that's actually a nice filter. I think it's probably a little bit more focused than, say, just a Google search for COVID-19, or you might run into, say, search engine optimization and some variable results.
All right, buyer beware.
That's right, exactly.
So one last question for you. We are at the end of August, and what advice do you have for people who have neuroendocrine tumors about, can we go out? Can we go to a restaurant? Is it okay to go to the grocery store? Again, right now, before flu season hits, because I hear you're concerned about that. What do you tell your patients?
Yeah, so honestly, again, short of aerosolization where the particles are actually hanging in the air, and actually as healthcare workers, we're the most at risk for that. So when we do put someone in a ventilator, we are generally putting a tube down their throat, and actually that generates a lot of aerosol. So the average person, thankfully, is not a massive risk for aerosolization. It's mostly direct contact with droplets from another person or surfaces. So what I would say is, obviously, we still need our essentials. I completely understand why people need to go to the grocery store. And so the way I do it is I ask myself, how vital is it that I do activity X? Like, I need groceries. And even there, we have opted, and we're lucky to have this, I suppose, for curbside pickup. So we actually minimize our interaction with the actual store and people in the store. And then also there's kind of the eyeball test. I mean, if you drive up to a restaurant and people are clearly sitting close together and not masking, and masking is not being enforced, maybe that's not a restaurant you want to go into. And I do understand, small businesses, need to continue, providing a service so that it can remain profitable. Frankly, we've opted a lot for takeout and delivery, way more than we did before. And again, that's a way we can support local businesses, especially non-chains, but not actually risk going into the venue itself. So there's no perfectly good answer, Elyse, that covers all scenarios. But again, my refrain is the virus is largely spread person to person. If we literally all separated from one another, went into total isolation, and weren't breathing or touching surfaces that were shared, the virus would go away. It doesn't have any way of surviving without a host. And obviously it's impossible to achieve that kind of total shutdown without complete economic catastrophe. And we've already had a huge problem there. But it just goes to show you that this is not a virus that is going to linger for years, provided we can follow some of these really basic measures. And I'll say, I know the mask is uncomfortable, but I wear it for 8 hours straight in clinic, and I don't have any problem with my oxygen or carbon dioxide. So I really think masking is hugely important, frankly, almost a civic duty.
Thank you, Dr. Lewis. So wash your hands, wear your mask, stay at least 6 feet apart.
That's exactly right. And again, those things we have known now for a little while. And I know the mask recommendation kind of flip-flopped, but now I think it's pretty clear that provided we have enough PPE, everyone should really be masking.
All right, thank you very much. So we've been talking with Dr. Mark Lewis, who is joining us from Intermountain Healthcare in Salt Lake City. And if you want to know more about some of these questions or anything else having to do with NETS and COVID-19, please go to our website, netrf.org. And thank you for watching. Bye-bye.